This is the Made for Living Well podcast, hosted by Alexa Sherm, the place to create a life well lived.
Welcome to today's show. We are in the middle of a podcast series called Health School, and I have been having a blast with it. I hope you are as well. And while I've been very diligent of keeping those shows in a shorter format, today on the podcast, we do have an interview. And each month, we are going to be hosting an interview inside Health School where I cannot promise these shows will be short, but they will be filled with information. So just note, today on the podcast, it's a little bit longer simply because I have a hormone expert, Dr. Jolene Brighten, on the show to dive into all things hormones, including birth control, menopause, hormone therapy, and so much more. And I'm so excited to have Dr. Jolene on the show. She is a naturopathic endocrinologist who specializes in women's hormones and is a prominent leader in women's medicine. As a licensed naturopathic physician who is board certified in naturopathic endocrinology and also a clinical sexologist, she takes an integrative approach in her clinical practice. Dr. Brighten is a best-selling author who takes pride in empowering women worldwide to take control of their health and their hormones through all of her education on her website, her social media channels, and of course, inside her latest book. You can learn more about Dr. Brighten by visiting her website. That's drbrightenessentials.com. I will make sure and link up all of the resources, including her book, her website, and her social channels over at thelivingwell.com. You can use /331 to be taken right to today's episode. Details, descriptions, resources, and of course, I always lay out a bit more information in those actionable steps that you can take to apply today's podcast to your life, which is the only place health exists, is in the action you take. So make sure you head on over there to get started taking action. But first, make sure you listen to today's podcast to get all of the details on hormones. So let's welcome Dr. Brighten to the show. Welcome to the show, Dr. Brighten. I'm excited to have you on and to dive into hormones throughout all the life stages today. We're going to hit it all, or try. Yeah. I want to start with early on in our life phase, as we're young adults and we have our menstrual cycle. And it seems like women everywhere are having all sorts of hormonal issues, autoimmune conditions. And the best answer to date that a lot of women are getting is just go on the pill. You've written an entire book about this, but I really want you to talk about that because I don't think it is our best option. And what does that mean? Because I think we do need relief, but how do we get there without using something synthetic like that?
Okay. The birth control pill is one option. It's always an option unless you have a clotting disorder, unless you have auras, when you get a migraine. So when you're seeing like little flashing lights and when you get extreme headaches, like migraines, like there are, certain conditions where the pill can't be used, but those are much more rare. Mm-hmm. However, while it's always an option, I think it's important that we explore all of the options. And that has been the big shortcoming of medicine, in that you go to the doctor and you tell them, I've got hormone issues, period problems, like fill in the blank if it's lady part, and people who can't see me doing quotes, lady part related, then you get the question, do you want to have a baby? If the answer is no, you are offered hormonal birth control. If the answer is yes, we got to work it up. We got to figure out what's going on. All hands on deck. Let's do lab testing. And I call bullshit on that. You should never be reduced to do you or do you not want to have a baby in terms of medical decision making. Now, I say that it does absolutely matter whether or not you want to have a baby. Okay. I'm not saying that doesn't matter. But if you say you do not, that doesn't mean that all you get is the birth control pill or all you get is an IUD. And you get no one else investigating what's going on and asking more questions. So I just want to be really clear about that for people. It absolutely does matter, your wishes on whether or not you want a baby. But just because you choose not to pursue that path or you want to delay that doesn't mean that your symptoms do not matter. And why it is so problematic is that we so often see the birth control pill being used primarily for symptom management no
Right.
question as to why you have those symptoms, and for you only to discover decades later in your life that you end up with PCOS, endometriosis diagnosis, hypothyroidism, fibroids, ovarian cysts, like the myriad of things that we face that do have a root cause intervention that can help. And here's the cool thing. You can do nutrition and lifestyle, even supplementation, and still use the birth control pill if you choose to do that.
Yeah. Do you feel like the root cause treatment amongst a lot of these different conditions is very similar?
It is similar in this way. We always have to look at liver. How well are you fueling your liver to run detox? So it's something that whenever I'm asked questions about vegan and vegetarian diets, I always say, protein doesn't just happen. Same in an omnivore diet. Protein doesn't just happen. You have to be conscious in your decision to eat protein. It's just like vegetables don't just happen onto people's plates. You have to make that decision. And why I bring that up is because these things are necessary for liver detoxification of our hormones. Amino acids are absolutely essential, as are many nutrients that you get from your plants. And these same things you need to run your liver detox pathways, nutrients can be depleted by being on hormonal birth control. So it always, whether you're having symptoms on birth control, symptoms that may make your doctor prescribe you the birth control, we have to look at liver health. We have to look at gut health, because we've got a whole estrobolome that is the microorganisms involved in how our gut is functioning. You brought up autoimmune disease. If we've got autoimmunity, which is, so let me back this up. Okay. Because I'm like going to launch into this. I'm like, people might not know what is autoimmune disease. So autoimmune disease is when you lose tolerance for yourself. Your immune system is out there serving, and it should see a bacteria, it should see a virus, it should see something that's not you and be like, I have to put you in check. And I have to tell everybody you're a problem. And it does that by way of inflammation and cytokine signaling and an attack. When we have autoimmune disease, we've lost tolerance ourselves. Our body sees you and is like, I don't know about you. I'm going to hassle you. And that can ramp up over time until it's full on destroying your own tissue. So with women, our immune systems are very powerful. We've always understood this, that when you think about just in terms of our immune health and our hormone connection, this cannot be overlooked, that the development of autoimmune disease, we need three things. This is what Dr. Fasano defined, not myself. It is the three ingredients to autoimmunity that bakes you the cake of whatever your genes decide. And so number one is you need the genes. Can't control that. Nothing you can do about that. Good news is just because you have genes doesn't mean you have to turn them on. Epigenetics comes into play. The second thing you need is intestinal hyperpermeability, leaky gut. And with leaky gut, that is something that can be induced by hormonal birth control, by over antibiotic use of NSAIDs for our periods, so ibuprofen. That can be something that you get food poisoning, you get leaky gut. So there's a lot of things that can trigger the gut to become leaky. It's not always necessarily bad to have, moments in your life where your gut is a bit leaky. I'm saying this, and I'm like, I should define this as well for people who don't know. So if you can see me, I'm making tight junction gaps. If you can't, put your fingers together, the webbings of your fingers together. This is how the cells should butt up against each other. And nothing should really get through that hasn't been digested well. But the problem is with leaky gut, space begins to be created, and now larger proteins can get through. So things that are not well digested. Also, so this is where food sensitivities can develop from, but also bacteria, viruses, yeast, different organisms as well can trigger the immune system to get hot and bothered, because the majority of the immune system sits in the gut. Now, the third ingredient you need is a triggering event. And for women, starting the pill, stopping the pill, perimenopause, menopause, starting your period, going through pregnancy. Pregnancy can be a time that we see Graves' disease come on. That's one type of autoimmunity of the thyroid, is hyperthyroidism. And then giving birth, that's a very common time to see hypothyroidism by way of the autoimmune disease, postpartum thyroiditis. So back to the question of okay, things that come, are a lot of these things, the root cause things are similar. We've got to be taking care of our liver. We've got to be taking care of our gut. As I talk about my new book, Is This Normal? I go a lot more into stress, into sleep, to these things that a lot of people are forgetting, or they're just glazing over because it seems like it's been said and done, and yet it really hasn't. And then the other thing is environmental toxins. And whenever people ask me PMS, you say it's common but not normal. But if upwards of 75 to 90% of women are experiencing PMS, well, wouldn't you say that's common? No, it is a physiological adaptation that's happening in our environment that is resulting in symptoms of PMS, in symptoms of TMDD, in issues like developing fibroids. We see so many conditions, endometriosis tied into environmental toxins. So we are living in such a unique time in the world in which we have rapidly accelerated in terms of how much we're supposed to be working, how little we're supposed to be sleeping, how many environmental toxins we're exposed to, how much technology is really inundating our minds. And on an evolutionary level, as an organism, we have not evolved to keep up with any of that. And so the compensation, that's what I want people to understand. It's not your body betraying you. It's not your body's dysfunction. It is your body's compensation to an environment that is not serving it.
Yeah. And I love in your new book how you bring all of this in, and even you start talking about the hormonal hierarchy, because I don't think we recognize this continuous feedback loop of everything is really interconnected into your biology. And like your hormones are not separate from your sleep patterns or your stress or, even like you talk about the sugar regulation. And I do think that there is this level of a lot of the things inside a woman's body are they require a lot of energy, right? Like they're high energetic processes like birth, labor. And yet a lot of the women in general diet terms have had this mass reduction. Like we're taught to work really hard, but also don't feed our bodies, don't nourish our bodies, kind of overexpend ourselves. Like it's kind of like this badge of honor. Can you talk a little bit about this hormonal hierarchy and how this is affecting later on our sex hormones?
Yes. Okay. So I love that you bring up blood sugar, because this is something that people don't tend to think is an issue until diabetes is knocking on their door. And so for people who don't understand how this works, and even if you do, I will say review is always a good thing. So we have a pancreas that is one of the endocrine organs. It releases a hormone called insulin. This is in response to you taking in sugar. And it can also be in response to you getting really stressed out, and then your liver liberating the storage form, glycogen, breaking it down and liberating glucose into your blood. Now, insulin is the one who's going to vouch for glucose. It's going to come up to the cell and it's going to dock on the receptor, and it's going to be like, this guy's cool, let him in. And the cell's like, great, we'll take in glucose and now we can generate energy. Like, this is fantastic. Now, with insulin, we are familiar with insulin resistance, most of us, as it relates to diabetes. It's important to understand that comes first. So just like autoimmunity, antibodies come first, destruction comes second. In insulin resistance, we will not, if I am already seeing changes in your blood sugar, so I measure a hemoglobin A1C, it's a marker of what your blood sugar has been in the last 3 months, and I'm already seeing you in the pre-diabetic window, you've had insulin problems for a while. And that's why it's so important, I believe, to be testing fasting insulin in people, because those insulin levels they're going to get off kilter before the blood sugar issues come on. And blood sugar being high, people may be familiar that, like, yes, you can lose your eyes, you can lose your kidneys, you can lose sensitivity to your fingers and your toes. You can also lose sensitivity in your clitoris. It can lead to sexual dysfunction. We well recognize this in men. The penis is the same tissue as the clitoris, embryologically speaking. And we have lots of penis research to tell us that high blood sugar and cardiovascular issues, those are damaging to that tissue. It can lead to erectile dysfunction. Women have erections too. So it is very important in that. So insulin is one of our foundational hormones, because if there's insulin resistance, now we're not getting enough blood sugar in. Now we're getting too much sugar going on. Now we're getting inflammation. The other hormones have to shift to compensate. Now, at the bottom of the pyramid that we're talking about, and I have a graphic in the book. So the base, we have insulin and we have cortisol. And really, DHEA can be in there as well. That's another adrenal hormone. But if your stress and your blood sugar balance isn't right, then the next system up is the thyroid. And the thyroid is going to start to fill it. And the thyroid's going to start to shift and compensate. But the place where we all absolutely notice is
Right.
the very tippy top when what are called sex hormones, which is really an awful name for them because yes, they're involved. Well, because like social media won't let me say sex hormones.
Yeah.
And also because they're not just about sex. They're about brain health and cognitive function. They're about heart health and how well your entire cardiovascular system can function. They're about your muscles and your bones being at their best. So I want people to understand, well, these are sex hormones as they've been categorized, and they affect your period, and they show up by way of PMS or long cycles or infertility or missing periods. They're also, if they're showing up in your reproductive system in that way, just like insulin comes first, listen, they have already been affecting other systems in a negative way. And so if we want to optimize sex hormones for the long haul, we always have to work on that foundation. And as you brought up the life cycle, when you are pregnant, okay, no period, then you have a baby, no period for a period of time, you still have to be working on those foundational elements. When you're in perimenopause, if you do not work on that foundation, friend, it is really an uphill battle that you're going to face, because as we transition into menopause, that foundation is all we have left. That's it. Because the ovaries have retired, they moved out, they're like, I'm done here. And you are now going to rely on the adrenal glands for testosterone production, for a bit of estrogen production. But also, as estrogen declines, your ability to control your blood sugar, your insulin sensitivity also goes down. Now, insulin's knocking on the door and the cell's like, I just don't have time for you. I'm not coming to the door. And then you pump out more insulin, and the cells become resistant to that. And that's where we can end up seeing women who are postmenopausal having diabetes. But I'll tell you, we don't often, so for people who are like, well, what does that look like? We don't necessarily see right away that like you're having, the extreme symptoms of diabetes. I talked about like kidney damage, eye damage, fingers and toes feeling numb, tingly. We don't see that. We start to see belly fat, visceral adiposity, building it up in the midsection. So if right now you're over 35 and you're like, I am gaining weight around my belly, that's a bad sign. That's a bad sign, but you can do so much about it. So catch it now.
I always think about like the hormonal hierarchy, and we always get stuck at the top. Like you said, a lot of people get focused there. And I think those symptoms up there are maybe noisier or more annoying, or we appear to like
absolutely
scary,
or
right?
Scary.
And so like when we work down the chart, we're always like, oh yeah, I should take care of my blood sugar. But your body has to do that for you. So there's so many processes of compensation that it's not this like glaring red flag all the time. But I love how you say that really sets the stage for the next phases of your life. Because when we start to move from the early stages of hormonal health into more perimenopause, I think women start to get a little bit more nervous. Like, what is this going to look like? Like menopause carries with it a lot of fear, I think, for women. And I don't know that it should, but yet I don't know that we live a lifestyle where it also is never going to be a fear. Or what I'm trying to say is, okay, when we move into the next phase of perimenopause, when does that happen? What should we notice? And how can we then make that the best journey into menopause?
Absolutely. So first, I want to just echo what you said. It shouldn't be scary to move into perimenopause and menopause, but it is totally normal if you do feel afraid, because society has, invalidated this as an important part of our lives and a part of the journey, and has really said like, oh, as women, like if you can't have babies, like what worth do you have? If you don't have your youth, what worth do you have? And I have to say that being a clinician, I just remember being in my 20s and listening to the women in their 40s and 50s and realizing the confidence that they exude, the wisdom that they carried, not just about life, but about their body. The lack of cares they had for people judging them and chiming in there was just so much that I was so in awe with. And it was always my goal to like carry the mindset of that wise woman as early in life as possible. And so I just want to say that because there is nothing to really fear about, the things that we know. It is the things we don't know. And research has really disregarded this phase of life. And I say that, like, I get that there's a lot of things like to be afraid of, but I don't think it has to be this fearful experience, or you're even, thinking like life is over at that point. I mean, I remember, I don't know, if this was true for you, but I remember thinking at like 14 that like 40 was so old and done and over. And now I'm in my 40s and I'm like, now I understand what people were saying, that like you're just getting started. Like you spend so much of your life like figuring out how other people want you to be. And then you arrive to this stage where you're just like, oh wait, this is who I am. And it's awesome. And I'm not doing this anymore. And we should talk about like, people are like,
no, I mean, I think that this time needs to be celebrated. And I think there's so much to offer. Like you said, like there's so much wisdom, more consistency, even maybe inside your biology, that it is a time that maybe should be more celebrated than feared. But we have to understand it. Like you said, I think that a lot of fear comes from not fully understanding and understanding what we can do to support ourselves through it.
Totally. So perimenopause, menopause, let's flesh these out. So menopause is the one-day event, the anniversary of not having a period for 12 consecutive months. You get one day, the next day you're in postmenopause. So that's it.
That's
12
very
months,
anticlimactic.
no ovulation, no period. I know, right? But I'm like, man, in some ways I'm like, we should really be like, I don't know. We'll see when I get there. Will I like count it down? Will I throw a party? People always throw like over the hill parties and they wear all black. And I'm like, I kind of like that. It's like, it feels very like, I don't know, like people would say like when your vehicle's murdered out and it's like all black, like it just feels like you're so badass. Like, I'm stepping into my badass area. Anyhow, if you're menopausal, let me know. Like, did you have a party?
This should be a new
step into
trend. It's going to be all over Pinterest after this.
I know. Somebody's going to make it a trend and then I will follow you in a decade or so. So when is it acceptable to be in menopause? This is what's really crucial to understand, because I will have women say to me, oh yeah, I'm 39, I haven't had a period in a year. My doctor says you're in menopause. And I'm like, get a new doctor immediately. Get a new doctor, because it is not acceptable to be in menopause until 45 or older. The average age of menopause is 51. If you are not having a period at 39, you have primary ovarian insufficiency, hypothyroidism, you have something else that needs to be ruled out. So 45, the acceptable age. And we know that perimenopause can start about a decade in advance. So 35 is a typical time to start seeing changes in your body. And by your 40s, you are likely going to be in perimenopause. Now, I say that as somebody who just turned 43, and I'm going to share a bit about my personal story. I hope this is helpful for people. So I turned 43. I had never experienced a hot flash. I still haven't, outside of a Lupron treatment I had to do. So I had my last baby at 40. I got pregnant 4 times at 41 and we were trying to have another baby. I subsequently met with all these fertility doctors who told me that I was just old and that my eggs were old and I needed to do IVF and like make sure that higher risk of trisomy 18, these different things that can be fatal for mom. They're like, they definitely are like, there's reasons for this. So I do this. And through the course of that, I end up developing endometriosis. Now, here's the really funny thing. I wrote this book called Beyond the Pill. I talked about don't use the pill to cover up symptoms because someone may very well figure out, like when they come off the pill, they have this disease condition that should have been managed. I was put on the pill for very heavy, painful periods. I get diagnosed at 42 with adenomyosis and endometriosis. And I first was in denial. I was like, how? I've not had painful periods since I got my business under control. And then I just had to laugh that I was like, I wrote that book, but I didn't think I was going to be the person in the book. I didn't think it was going to be me. So because of my age, so as it turns out, after I get like all these eggs and embryos and everything, but then like a transfer fails and I have adenomyosis and endometriosis, of course it would have failed because there's inflammation, there's things to be taken care of. And I want people to understand the reason why this was triggered through IVF is because my doctor saw signs of this, but continued to push my estrogen up, my natural estrogen, with no regard for the fact that he saw these lesions. And that is what really took it over the edge. So it is not that IVF will trigger this in people. It's that if you have the predisposition, if you have the predisposition, the lesions are there and they can grow. And it was definitely medical mismanagement on his part. And I am not trained to read ultrasounds for diagnosing endometriosis, and I'm not a reproductive endocrinologist. So anyhow, I share all this as it turns out I had 3 consults after that, and they were like, it wasn't actually your age or your eggs. Like it was, what was going on with your uterus. I'm like, fantastic. Because, 2 years later, here I am. And because of my age, I had to go through Lupron treatment to rapidly shrink these tissues. So I want everyone to know that everything I've done to live my life, I have managed this naturally. And I would have went back to that. But when I talked to my doctors, and 3 of them, they were like, you don't have 6 to 12 months to really work on naturally putting this into remission. We need to do it rapidly. So I went on Lupron. And why this is important is that puts you in menopause. You do the injection, and within 2 weeks, you're in menopause. And that is rapid. Perimenopause is this long transition, and it is a beautiful time to start figuring out your body and planning for things. I had never had a hot flash or any issues until that Lupron. And oh my gosh, and I also, this is controversial with people with endometriosis, but knowing what I know as a hormone expert, I used an estradiol patch, the lowest dose possible to protect my brain and my bones and my heart and my sanity, and to help mitigate some of those hot flashes, and progesterone therapy because I don't do well when I don't sleep. And progesterone is actually good for endometriosis. So I say all this because and so now that like Lupron's out of my system and everything, haven't had a hot flash, haven't had any of the symptoms that I had. Just because you are 43 doesn't mean that you will start having symptoms, but it does mean that you are likely in that perimenopausal phase, right? So because the average age is 51, I can look at most of the women in my family, they didn't talk about menopause, but based on what I could gather from the tampon situation, this was happening more mid 50s, not early 50s. And so I'm like, I probably have a couple more years before I get into that 10 year window. Women in my family also have babies like into their 40s, which is why I'm still like fertile AF. And yet still, which is kind of crazy. So I'm sharing my personal experience here because I think there's a lot of clinicians out there that until they arrive in it, they really don't get how extreme this is for patients. Now, I knew this was coming. So here's some of the things that I did. Number 1 is I started upping my sleep. Like the month before I knew that injection was coming, like I did a whole month protocol to start ramping up. So I started increasing my sleep. I started strength training. Let me tell you, thank God that I did, but I lost muscle mass and I gained weight, and I started gaining weight for the first time in my life around my midsection. And I was like, oh my God, my insulin. Yeah. And this is somebody who eats fat, protein, fiber at every single meal. But I also started upping. So I have a women's probiotic. I was taking that, and then I just really started upping my game of like making sure my prebiotics were coming in with that, and making sure that like I was taking care of my gut as much as possible. Other things that I did is I actually brought on saffron as a supplement because I wanted to safeguard my mood. I started drinking turmeric tea daily, like it was my job. Like I was the CEO of like turmeric intake because I wanted to make sure I kept my inflammation low. And I ended up also leveraging 5-HTP and L-theanine. So I have a product called Adrenal Calm that has L-theanine in it. I take it at night, but I also needed L-theanine in the morning. So everything that I'm describing here for people, this is to mitigate my mood because I wasn't going to have 10
Right.
years for my body to adapt to this change. I literally got 2 weeks. And let me just say, I'm so glad I did all of this, because there was a moment when we're going through the holiday season, and that was like my big motivation, is like, this is 1 year out of possibly only 18 I might get. I don't know what I'll get with
Yeah.
my children. Like, so I'm like, holidays are very important to me. And there were some days, because it's holiday season, that I would forget to take my supplements.
You
Oh my God,
noticed.
I would feel it. Oh my God. I would be like, 1 minute I'm raging, 1 minute I'm crying, 1 minute I'm just like, I'm going to bed. And I'm like, what's happening? And I'm like, oh, well, that's a good
Yeah.
test to know. So I bring up these things because there are people who are like, we don't have extensive research on women in menopause and supplements that can help. And I'm just like, oh my God, I did not have the time to wait around for you to decide to fund a study. And women don't have that time. So I just share a bit about my personal experience, because these things that I did are the things that I've been using with patients forever. And people will often be like, well, yeah, maybe your patients aren't telling the truth or this or that. I'm like, I don't know. They come back, they seem happy. And to get to use these protocols on myself, I was like, oh my God, this works. And like, why are we not telling more women about it? So if you are in the perimenopausal window, you need to be taking care. Well, actually, if you're 14, you need to be doing this, but so you need to be, I call it like, start training now for menopause. So like, I have a walking desk. I wear a weighted vest with that. Why would I wait? This is something that often gets prescribed to women who have osteopenia or osteoporosis. Why would I wait for that? Why don't I just do it now? I'm in training for menopause. Like, I'm going to train for this. I'm going to lift weights, because we lose muscle mass. And as we lose those hormones, that affects our skeletal muscle. And as we lose skeletal muscle, that affects our increased risk for chronic illness, but also falling, dying, or just dying in general. It is not a good state to be in. Your muscle mass and the amount of mitochondria in them are correlated to the amount of mitochondria in your brain. And if we want to prevent Alzheimer's, dementia, and, around 38% of women in perimenopause are having adverse mood changes. Lifting weights can help with that, as well as eating optimal amounts of protein. Now, when I say optimal amounts of protein, it's going to be at least 1 kilogram for every gram. No, I messed that up. It's going to be at least 1 gram for every kilogram of your body weight. And that is important to understand, that in perimenopause, you need more protein, because muscle's super expensive and you're not going to be able to keep it unless you're eating, and it has to be complete proteins. You need your branched chain amino acids, leucine, isoleucine, and valine. And you have to absolutely be looking at building community now. And this one gets slept on. Women who live long and healthy lives have community and people they can rely on. So I talked very briefly about supplements. I want the driver to be lifestyle matters greatly, but I also just talked a whole lot. So let me pause and let's have a conversation. You let me know what
you just dropped so much good truth. I mean, even there right at the end, to not let that get buried, but community matters. Your lifestyle matters. But I do want to take a minute to say thank you for sharing your story and being real, because I think when it comes to the world of hormones, it feels very black and white. Don't do this, do this. If you do this, that's wrong. And I think what you're trying to show is hey, I did this stuff and I still had a moment in my life where I needed the external support. And I don't think we should shame or bully ourselves. That's not helping in any case. I think everyone's doing the best with what they have. And just, I do appreciate that you said that. Hey, I wrote a book on this and then I had to go on it. And I think that's very real. And
it's so lame that, well, I mean, I spent a decade on the pill, and it's funny because people have said oh, well, that probably is what kept your endometriosis in remission. I'm like, absolutely not. Because when I came off of it, what I describe in my pill or in my book, Beyond the Pill, is when I came off the pill, there were the most horrific periods. They were so heavy again. They were so painful again. I was so sick. And it's likely like, I got pregnant naturally once at 31 and then, once at 40. And there was likely just that adenomyosis, endometriosis always waiting in the wing. But had I not gotten a degree in nutrition science in my early 20s and actually been eating in a way that helps with management of these chronic conditions, like where would I have been? I don't think it was the pill absolutely masked what was going on. My doctor should have investigated further, had a conversation with me, and that's something that should have been discussed. But why nobody even thought to bring it up ever again is because I got pregnant naturally twice. I didn't have heavy, painful periods. I didn't, and I was like, I had a history of it, but now I no longer have heavy, painful periods. I don't have pain with bowel movements. I don't have pain with sex. I don't have pain with urination. Like I don't have any of these symptoms. After my last egg retrieval, I was in so much pain. And this is where, like, if I was a man getting a vasectomy, I would have gotten opioids. But after having somebody puncture through the wall of my vagina and scoop out a bunch of eggs from my ovaries, and I woke up from that in excruciating pain. And they were like, we're giving you pain meds. They had to do an ultrasound right there because I was like, my body was like shaking and I was crying. And it was horrific. And it took like months to recover. It was bad. And when I look at that and now and the symptoms that came up, I'm just like, oh my God, it was so obvious that was endometriosis. It's like, it was so obvious. Like, and then when I came back with the MRI, like showing it, you're going to love this. When I came back with the MRI to my doctor showing endometriosis, he was like, yeah, we had seen it. Like, I've seen it. And I'm like, and he's like, but there's nothing we would do differently. And I was like, okay, that's bullshit. And then I was like, and then adenomyosis, like, this is problematic. Like, we can't, do another embryo transfer. And he said to me, that's just the trendy diagnosis, like ADHD. Every woman thinks they have it. I'm like, this is an objective finding on an MRI. And I see you trying to gaslight me, but not today, Satan, get behind me. Like, I am not doing this. And I was like, and I also have ADHD, which has a higher, like the fact that I'm neurodivergent means that I'm more likely to have one of these conditions. Like, get out of women's medicine, go home, like talk to somebody. And like, you need an intervention of a new career, because absolutely not. But as I'm sitting there as a doctor hearing that, I can't help but always empathize for patients, like hearing that and having my own experience and just thinking, what chance does the average individual stand when even doctors are facing gaslighting from other doctors and running up against all of this? And I know what I know to be like, no, I'm out. I'm getting not just 1 second opinion. I'm getting 3 second opinions. Like, I'm done here with this.
I mean, it's unfortunate. I mean, even across the research, I mean, we're hearing more and more about this. It's a man's world, and men are studied, women aren't. Women are hard to study. I understand that, but we do deserve a seat at the table. And I do think it's important that you stand up for yourself and you're not just crazy. And I think a lot of, you go to a lot of physicians, and when you get into hormones, it's like, oh, it's just in your head, or it's just crazy, or, here's a quick fix, instead of really looking at the individual. And I think what your story proves, and I mean, I could talk about my own, is like, it's all so individual, which I think brings me to a question that I get asked a lot. Like, when is there a time and a place for needing synthetic hormones? Is that a good option for the average American? Like, it feels like, when we get into hormonal health, I see a lot of women who are perimenopause and going through menopause, and they're like, well, I guess this is what I just do now, is just take the hormones. Is that something? I mean, I want to be very cautious in this area, because as we talked about, this is very individual. There's no black and white. Yeah. But what do you feel like about the synthetic hormone use? And do you feel like, because of our lifestyles today, because of our environments, that is kind of just where the majority of women are going to end up, or not at all?
I think that bioidentical hormones, I've been prescribing them for over 12 years now. I think that they should have always been part of it. I mean, people would call me a quack back then. They would be, I remember getting an email from a doctor being like, you're going to kill my patient by giving her topical estrogen. Don't you know she's going to end up with a clot? I'm like, don't you know topical estrogen doesn't do that? You're going to give her breast cancer. No, we're also giving her progesterone, and also we're monitoring her. And we're supporting her liver detox pathways so that she optimizes her estrogen metabolites and doesn't end up with metabolites or in poor methylation status that can put you at higher risk for breast cancer. And also, spoiler, now the new research tells us that being without estrogen might be what's putting us at risk for cancer. And also, you could not ever use bioidentical hormones and still end up with breast cancer because the environment and the way that our genes are being turned on, it's more than what we've seen before. So I do want to say the S is that people will often say like, well, you're against birth control pills, so therefore like you must be against bioidenticals. I am not against birth control pills. I think they have a time and a place. I think what I am against is telling women that's their only option, the overuse of them. The birth control pill works by shutting down your brain ovarian communication. And then your doctor tells you your cycle has been fixed. Well, how? I'm not cycling. A period only comes after ovulation. And if that pill is doing its job, then you're not ovulating. Like telling women that they're fixed, telling women there's no side effects, gaslighting women that like, you know, the only way to fix this is the pill and the side effects you're having, that's you, that's not the pill. These are the things I take issue with. But there are definitely a time and a place to use birth control pills. And I'm not a fan of using them in perimenopause and menopause. And I will explain why. So the hormones that we use for that later phase of life. So firstly, the pill was only studied to be used temporarily, like a couple years to space pregnancies in young women. It was not designed to stay on it for decades on end, but it was certainly not designed for perimenopause and menopause management. Do some people use it? Yes. Do some people feel better with it? Yes. Do some providers only feel comfortable prescribing it? Yes. And what's crazy to me is that they'll hate on like using like an estradiol patch or progesterone cream or oral micronized progesterone. And that because they're like, there's not enough research around this. And I'm like, well, I don't know if you know this, but the pill's got a lot of question marks and no data to actually back it up. And really, there are a lot of using the pill in perimenopausal women is operating under the pretense that the absence of evidence is evidence for its use. And that's just not correct. So when it comes to hormone replacement therapy, what we understand from the research we have, the sooner we start it, the better. The Women's Health Initiative was incredibly flawed. Thank goodness somebody even cared enough to try to do this. Okay. We can acknowledge that like they at least cared about us enough to study this. However, when you start administering hormones, this is what we learned from it. 10 plus years from menopause, you actually may increase the risk of certain conditions like dementia, cardiovascular issues. But here's the thing. If you have any other medical condition, like you have diabetes, and we let that go for 10 years. We know you have diabetes. We just let it go. Do we ever expect that we can come in with insulin and reverse all the damage that was done to all of your blood vessels? We do not. So while menopause is a natural state of being, it is happening at the wrong time, in my opinion, because we live so much longer. And if we were living only until like 50, maybe 60, it makes sense. But now living till we're 80, it does not make sense to go almost half of your life without hormones in some instances. So what we have learned is that the closer we start it, even better is often that what I call that late phase of perimenopause, that like 12-month countdown towards having that menopause anniversary date, starting it in that window. Sometimes we start it even sooner. So, and there's lots of times I've used progesterone replacement therapy in a woman's life. Progesterone is such a fantastic hormone. Progestin is all you're getting in contraceptives. You will only get progestin in an IUD. Could that help with your heavy bleeding? Sure, but it will do nothing for your brain in the way that progesterone can. Progesterone, when taken orally, is metabolized, and it is its metabolites that help ease the anxiety and put you to sleep at night. That's all happening in the brain. And so progesterone is also involved in like creating the myelin sheath of the brain. Like these hormones are so, so important in brain health, and you're not getting those in birth control pills. And I want people to understand that they are different hormones, even though your doctor may be like progestin, progesterone, I use them interchangeably. Sorry, you're still wrong. Like as somebody with a chemistry degree, I can put those two molecules up. You don't need a chemistry degree to see that they are different molecules and they interact differently. Where progesterone makes a lot of people feel less anxious and have better moods, progestin is associated with adverse mood changes in some people. So understand, it's not going to be true for everyone. Just as you said, it's individualized. So when it comes to hormone replacement therapy, I am a fan because I am a fan of your bones staying strong, you retaining your muscle mass, you not getting diabetes, you not ending up depressed, you forgetting every memory that you ever created in your life because you end up with dementia. Like I'm a fan of preventing all of these things, and we can. There are people that may not be a candidate for various reasons. There's a lot of challenge happening in the oncology realm in that people who have had breast cancer have always been told they can't have hormones. And now it's starting to seem like, well, some hormones may be beneficial. And that is always something that whenever I have a patient who's had cancer, I'm like, we have to defer to your oncologist because they are the primary provider you have managing that condition. And even if I read a study that's different, I am not as well trained in oncology, and I will pass them studies and we will try to have conversations, but we have to defer to them because they understand you and that condition at a much deeper level than me as a hormone doctor does. So does every woman need hormone replacement therapy? That's a big question mark that we have. Should every woman consider it? I think absolutely, because the benefits do outweigh the risk. And for people to understand that what it takes. So I was on 0.025 milligrams, of estradiol. We might be using more like 1 to 2.5 milligrams in people. So that's the low dose I was on. That's what it took. My hot flashes didn't go away with that, but it helped mitigate those. I definitely knew when I was getting to the end of the day, like the day I needed to change my patch, because I would have more hot flashes, but I also would notice that like I had a little more brain fog. I was a little more irritable. Like I was a little less happy that day. Like it felt sometimes like I lost my glow, like my shine was wearing off. And I'm not just talking about the aesthetics. I'm talking about like, wow, like the way my brain felt. And that is because estrogen is part of how your brain cells are fueled. You need it to run your brain power. So if you're experiencing brain fog, we have to look at estrogen and what's happening there. But again, I want people to understand, and why I'm very candid in sharing these things, because I think we have to normalize these conversations. There are people who follow me. I can't even tell you, people who were like, when I said I was going through IVF, my goodness, I got so much support, so many wonderful people, but there were many people in my comments being hateful, but so many more in my DMs being like, you're supposed to be this natural doctor, and I can't believe you're doing something so toxic to your body and you're influencing women to do these horrible, horrible things. And I'm like, look, until you've had 4 miscarriages in a year and experienced that loss and the toll it takes, and like knowing that you're still fertile and like the mental burden of all of it, like you can't live in my family, my head, my heart, none of that. Like don't come judging people. And I think, you know, as much as I like, sometimes I'm like cringe. I don't want to share about myself because like, firstly, I don't want to be like centering myself and stuff, but also like I get a lot of hate for these things that I share. And yet I'm like, I just think it's important to understand that like, I will always be food first, lifestyle first. I will always talk about that first as the mainstay. But once your ovaries retire, we just, with the amount of research that I've seen, but more importantly, my clinical experience of watching how quickly my patients degrade who choose not to use hormone replacement therapy, that has been something why I have always said, like, when my time comes, sign me up. Like, I am not going to be without these hormones because they absolutely give me superpowers. And for people who will say, well, what about men? Like, men aren't doing this. Oh, yes, they are. And actually, we're doing testosterone hormone replacement therapy is happening at a much younger age. Like, when, you know, 10 years ago, it was like, yeah, if you were in your late 40s, now we're seeing men in their 30s who it's warranted. It's not, people will stigmatize testosterone and be like, oh, they're just trying to get bulky and lift weights. And I'm like, if you see the numbers that my colleagues are seeing that specialize in men's health, you understand. And with that, yes, muscle is important. Like, let's stop acting like muscle is not important, but also testosterone for every human body on the planet is absolutely essential for our motivation, for our mood, for our immune system. When we talk about autoimmunity, lose your testosterone and you're going to be at risk for autoimmunity.
Yeah. I've even seen some interesting studies starting with testosterone and PTSD, especially in men, like crazy stuff, which when you go back all the way back to the hormonal hierarchy, when you're like, I hate how they're called sex hormones, like when really they affect your brain. And I'm like, so much of sex starts in your brain, like it really does.
Sex does start in your brain. Yeah. So maybe it's
I don't know.
We call it that.
Yeah. I mean, we're running out of time. And I do want to clarify one question. When you talk about hormones, you had mentioned like that 12-month window beforehand. Is that like a good time to maybe start getting them checked out? Or like what phase of perimenopause are you like, this is a good time to maybe start getting them checked out?
Okay. So if you are over 35 and you haven't had a full thyroid panel, get that done. TSH, free T4, free T3, TPO, and thyroglobulin antibodies must get that done. You're much higher risk after 35, and that should be annual. In my opinion, we should check it annually, because if we see the antibodies, let's put them in remission. Let's work on that rather than waiting until you have full-blown disease. So that's hormones to check. Fasting insulin, absolutely couple it with the hemoglobin A1C. That's like very minimum that we want to be looking at. When it comes to estrogen, progesterone, FSH, LH, not incredibly helpful if you're already in perimenopause experiencing all these symptoms. And why I say this is, one day I'll check your FSH. It's going to be like day 2, 3, 4 of your period. I'll look at your estradiol, and it may be that your FSH is off the charts and your brain is screaming at you. And it's like, yes, and you're not making enough estrogen and we've got problems. And then I could check it the very next month and you are fertile and you're ovulating and everything looks good.
Yeah.
Okay. So understand that there's so much fluctuation. When doctors say, I won't check your hormones because they change too much, this is the phase where it actually would apply, but I could still check your testosterone. And in women, I want to track total testosterone, free testosterone, and a DHA sulfate. I also like to do cortisol checking. I like to do it. I prefer doing a Dutch panel. This is like super controversial, but I get that if you're not trained in like understanding estrogen metabolites, understanding the balance of cortisol and cortisone, if you're not actually trained in all of that, then it seems like this test has no utility. I often see doctors that are like, it's so expensive. And I was like, if I price out all of these, like all the data I'm getting from there with someone using their insurance, the Dutch test is usually cheaper. Now, Dutch can't give you your progesterone directly, but it can measure metabolites that gives you information about it. It will tell you about estrone, estradiol, so E1, E2, and estriol, E3, the types of estrogens that you have going on. When you're still cycling, it's estradiol is primary. When you're not, estrone is primary. Then it also tells you about your metabolites. And if I see this in a patient where they push heavy into 4 or 16 hydroxyestrone, these are things that are associated. These are the types of metabolites that can stimulate cancer cells, that can stimulate growth of the endometrium, tender breasts. And so I already know we have to start working on those pathways. Very quickly, everybody, 3 key things that you can do to work on those pathways: DIM and sulforaphane, that is eating cruciferous vegetables and broccoli sprouts, specifically broccoli sprouts, and calcium D-glucarate. And that I usually recommend as a supplement. All 3 of those are in my Balanced Women's Hormone Support supplement, because that's going to help what is happening in the liver and what is happening in the gut in terms of your estrogen metabolites. And when we look at the research, like, just friends, if you're taking hormone replacement therapy, eat your broccoli sprouts every day. It's so good for you. And the research is there on that. So in terms, so I talked about those things. I want to see cortisol, cortisone. I want to see, testosterone. I was talking about that. DHT is the other one. I want to see DHT, and that's dihydrotestosterone, because if you're someone who has upregulated enzymatic activity that is leading to more DHT, then I know that when your estrogen starts to drop, you are likely going to lose hair on your head in the way that you never get it back. You will get miniaturization of the follicle. And I don't want anyone getting hair loss. And if you are someone experiencing that, I have articles on menopausal hair loss and what's happening in perimenopause and what you can do about it at drbrighten.com. But those are some of the hormones that we can be checking. But when it comes to estradiol and progesterone, FSH and LH, the brain hormones that orchestrate the menstrual cycle, if you're like, I haven't had a period in 3 months and I'm 49, I'm like, is not worth checking those. And in fact, when it comes to estrogen and progesterone, your symptoms are what guide us in terms of what we prescribe and how we prescribe it. That is very individualized and it has always been patient-led. And I think that's why a lot of doctors have shied away from it, because there is no absolute, like, here's the numbers of their estrogen and this is when you give it. You actually have to listen to your patient and you have to be in communication with them about using hormone replacement therapy. With testosterone, I always like to measure that first, because when they look like testosterone symptoms, we'll do all of the natural stuff to help support your testosterone, but I want to see the numbers before I give testosterone hormone replacement therapy. One, it's not FDA approved. It's an off-label use. And it's not, I just want people to understand, just because it's not FDA approved doesn't mean that you can't use it. Spironolactone is not, it's an off-label use to use it for acne and PCOS, and doctors do it all the time. So you can still use it. What that means is that nobody has actually studied it to be like, yeah, when you're losing muscle mass or losing your mind, we're not going to study that in women yet on testosterone. So that is something I do like to measure. And I also like to understand, like, if I give you testosterone and you already make more DHT, am I going to cause you to have oily skin and acne and start breaking out? Because first it's oily skin, then it's acne, then it's hair loss, and then it's hair growth on the chin, chest, possibly abdomen. And then you hate me. So I don't want to do that.
What's the difference between patches, pellets, injections? Like, is there anything that we need to know in that area? Because one, it is hard, like, as we've talked about, to find a practitioner that we really can trust and really knows this stuff. Like, what should people be concerned about? And then I promise I'm going to wrap it up.
Oh, no, it's all good. I feel like, I owe you guys like more tangible information, because I feel like I was sharing.
No, I love it.
And I'm like, I don't know. Was that a value add for anyone?
I always think the story is.
Okay. Well, pellets, I'm not a fan. I'm going to tell you why I'm not a fan, and somebody's going to come in and they're going to hate me for it. And that's fine. You can let us know. Usually as a practitioner who sells pellets, they're very expensive. Once they're in, I see like supra physiological levels of testosterone happening, and it can be really problematic. And like I said, we're guiding by the symptoms. So we're going by, like, how does this make you feel? And if I put a pellet in and you're feeling awful, like, we'd have to take that pellet out. And so here's the thing about estradiol patches, cheap. If we can get them through your insurance, like, you might pay, like, I mean, there's also coupons out there. So, it might be anywhere from $5 to $35 a month. And with patches, I love it because you can just leave it on and go, and there's no risk of it getting transferred to somebody else. When it comes to testosterone, sublingual troches can work well, or transdermal. The only thing transdermal that can get transferred to someone else. We want to be cautious about that. Progesterone, we can do that as a cream, but I really do love oral micronized progesterone. And this is one that, like, we can get compounded, or Prometrium. I can give that to a patient, and it's usually like a $5 a month prescription for 30 days. I say that because in some countries, like, it's more like a $60 for 15 days kind of thing. So, depending on your insurance and how things are coded, you can actually get access to hormones in a really, like, economical way. And so, it's going to depend on the individual. Sometimes we use estradiol creams as well. When it comes to vaginal, using estriol, so E3 suppositories or creams, because that's what can help with, like, vaginal dryness, the repeat UTI. Sometimes we're also using topical DHEA down there, which is a precursor to estrogen and testosterone. And that's because it can be beneficial not just for preventing vaginal atrophy, having vaginal dryness symptoms put into check by nourishing and plumping up those cells, but it may also help with the muscles in the pelvic floor. We need more research to really understand that and know, is that a fully true statement?
Yeah.
So that was like the quick rundown. There are lots of options out there. And I think it's just about finding what works with you, what's sustainable for you, what you can afford, what you can stick with, what you can remember. Like the estradiol patch is a twice weekly application. So if you're like, yeah, I just need to do something every day, then we might want to do a cream, because you might be like, I just end up forgetting about it.
Yeah. Yeah. And I love how you said like the economics, man, because I hear about pellets a lot and I'm like, man, those are so expensive. And, that's not practical for everyone. So then I think people get turned off from it and don't even get their hormones checked, so that there is lots of options.
Yeah.
Now, I did want to get into your latest book, Is This Normal? And we don't have time, but I love the book because you offer so many fantastic like questions that everyday people have. Like I wrote some down, like, how much sex should I have? Like orgasms, like, are they good for you? Like, how many should I have? Can you have multiple orgasms? And I did a whole sex talk series last summer where we addressed a lot of this, but your book really explains in detail a lot of what we talked about today and ask a lot of those questions. So I just want to encourage people to get it because I didn't get into that today. But the last question I have is like, I think when we talk about menopause and perimenopause and hormones in general, we get this really like confused, negative picture of it. Can you just paint like a picture of like what you presume? I know you're not in menopause yet, but like as you've seen patients in your clinic and, studying hormones, like what is that vision of what our life should look like when we get into that stage? Like, can we just talk about it in a positive way to end the show?
Well, I do, as you were talking about the sex piece, I talk about this in Is This Normal? People are always like, oh, once you get into like perimenopause, menopause, your sex life's over. I actually saw somebody on Threads the other day being like, old people don't have sex. And I was like, false. Old people have lots of sex, like so much sex that like we have to be just routinely screening them for for sexually transmitted infections, also like UTIs, all the, I'm like, you have no idea. Like when it comes to STIs, that's a very high population because nobody needs a condom anymore. Like they're like, I don't have to worry about this. So, right. Because there's no longer pregnancy prevention being top of mind. And that is one of the biggest things that I hear from patients and I see from patients is that when I entered into menopause, not only did I know my body more, I knew what I liked more, I felt confident to communicate more, but I didn't have to ever worry about an unintended pregnancy, that they get such a boost in sexual desire. They find that they are enjoying sex in a way that they never had. And I will say to anybody listening, I have heard from so many patients who are like, my biggest regret as I entered in menopause and I look back is that I never put myself first and I didn't, and that I always lived for everybody else and everybody else's needs. Take heed. When I heard that the first time, I was like, okay, note that. When I heard that the 10th time, I'm like, don't do that. Don't do that. Okay. Like I'm hearing this all the time, but there is something really magical that happens where you start, the way that the transition affects you, I will just say it's a really beautiful thing how people really step into fully loving their body, loving their life, creating a life that serves them, that works for them, exerting like their boundaries in a very positive way. I think that what you often see in the media is a negative depiction of a postmenopausal woman. And what I will say is what I've seen in my clinic are strong women who I've always wanted to be like, and I have always aspired to be that strong, wise woman who is like, so that when I arrive there, I don't look back and say, wow, I really wish I would have. I look back and I say, I'm so glad that they were there and I could listen. I mean, what a privilege I have to be able to learn from these women. And especially in a society where these women have been told like, oh, you have like, you're no longer in your reproductive years, like you're past your prime, like this really negative language is used. And, people will say like, it's very woo-woo to be like, oh, the wise woman, like, they are so wise. And like we would all benefit if we had that wisdom at 20. So if you are 20 now, listen to these postmenopausal women because my gosh, can they teach you so much about how to live your best life.
Yeah, I love that so much. Thank you so much for being on the show, Dr. Brighten. You have so much knowledge. Where can we learn more about you? If there's offerings for your clinic or working one-on-one with you, what does that all look like?
Yeah, well, you can find me at drbrighten.com, DRBRIGHTEN. Can I spell my own name? That is my main hub. You will find tons of information and resources there. My supplement company is Dr. Brighten Essentials. And then I'm all over social media. Ooh, can I say words now? At Dr. Jolene Brighten. And you can join in the conversation there. I think we have such a great time on social media. So I would love, anybody who wants to join a community of women who are taking charge of their health and embracing their hormones and the changes of life for the superpowers they have, then come on in, join us.
I will make sure and link all that up in the show notes, but I thank you so much for being here, and make sure you go out and grab her latest book. It is fantastic and will answer so many questions. So thank you again.
Thank you.
I hope you love that podcast as much as I did. You can learn more about today's show and understanding more about your hormones at thelivingwell.com/331. I have all of the links for today's show, including where to learn more about Dr. Brighten and grab her latest book. Again, you can get all of that at thelivingwell.com/331. Thank you so much for tuning in, and I will see you back here in the next podcast.